of you a warm welcome to each of you, our wonderful respected colleagues, to this first short online course on strategic planning for vector surveillance and vector control. We're very pleased and honored to have you as part of this course. So I should mention that strategic planning has been identified repeatedly on different platforms, including published platforms or publications in Malaria Journal and Parasites and Vectors and so on, as being an area where capacity strengthening is needed. And that explains why, we had such a strong response. But just to mention, well, again, we're very pleased and honored to have you as part of this course. The course is offered by the Vector Control Working Group of APMEN. APMEN, of course, standing for the Asia Pacific Malaria Elimination Network, which works very closely with and is closely integrated with the Asia Pacific Leaders Malaria Alliance, ALMA, which have as their shared objective to support the 21 member states in Asia Pacific to reach their malaria elimination goals. And they do a very good job. To say a few words of welcome to you, it's my pleasure to introduce you to Mrs. Amita Chebi, who's the Senior Director for APMEN. And as some of you will already know, Amita is a very special person, a highly competent and professional person, but also a very warm and kind person, and it's a pleasure to work with her. May I ask Amita to please say a few words of welcome. Over to you, if you don't mind, Amita.
Thank you so much, Leo. Thank you for those kind words. Good afternoon, everybody. As Leo said, I'm Amita Chebi, Senior Director, and it is indeed an honor to be here with you this afternoon and share a few thoughts, around the positioning of this particular course, this program, and the importance that it has as, countries in the region continue to make progress towards elimination. First of all, I'd really like to acknowledge the senior level participation, I think, on this program. It's so great to see friends and colleagues from all countries in the region, senior directors, program managers, whether it's from the Philippines, we have Pakistan, Afghanistan, I'm sure lots of countries that I don't want to spend time naming one by one, but really it's an honor to be in this august company. And of course, colleagues from the Vector Control Working Group who've been ably steering and managing this community of practice over the last few years to a place where it's really become, I think, one of the foremost places for technical expertise around vector control and surveillance in Asia Pacific. Today, I think just to say a few words, if we look at the progress that the region has made towards malaria elimination, we should really take a moment to step back and pat ourselves on the back for the progress we've made, even in the context of challenges placed by COVID. Across the world, Asia Pacific is probably one of the few regions where there was continued progress on malaria burden reduction, even through the 2 years of peak COVID response. And I think that's been made possible only because of the strong efforts of everyone that is, that are on this call today, in this virtual room. Where we are today, we have less than 8 years left really to meet our 2030 target of elimination, of regional elimination. And the reality is that we know resources are getting scarce, both financial resources, manpower resources. It's something that the Vector Control Working Group has really been acknowledging, grappling, and identifying solutions. We know that the Global Fund is going through a period of replenishment again this year. We don't know what the final number will look like, but the success of the replenishment will determine the amount of financial support that all our countries in the region will be able to access through the Global Fund. Even if we don't know the final number, I think it's safe to say that financial resources for malaria will be lower than in the past, partly because of the strong success that we've demonstrated. but malaria is no longer, as an endemic kind of disease in most of these countries. And so the attention and focus is going to shift to a lot of other priorities. But we, of course, need to continue to make progress towards the elimination goal. And so against this context, I think a critical question that needs to be asked and answered is, how do we deploy our limited resources in a strategic manner? And that's really the sort of objective of this particular workshop, which is the strategic planning element of vector control and surveillance. We know that we have the technical expertise, we have the technical tools, but to be able to deploy them smartly, that's really what we need to put our heads together. The way the elimination progress or the elimination journey has been going, we know that most of the malaria is now really eliminated from urban centers and urban cities. There are continued geographic hotspots in a few countries. And so when we think about, deploying interventions like vector control and, where to focus vector surveillance efforts, we need to become more strategic. We need to start thinking out of the box instead of really aiming for universal coverage everywhere. And that's what I hope we spend this afternoon doing, really thinking about our own national context, looking at the financial resources we have, and then coming up with nuanced plans for each of our country contexts. So with that, I'm going to hand it back to Leo. Thank you again, everyone, for inviting me to say a few words, and looking forward to the rest of the session. Thank you.
Amit, thank you very much for those insights and words of wisdom and the overview of where we should be heading and where we are heading. Very useful reminders for all of us. So thank you for those supportive words of welcome, Amita. We appreciate your sustained support for the vector control community in Asia Pacific. Thanks again, Amita. So let me mention again that we had well over 100 applicants for this course. I think we're currently standing at around 35 people attending. I don't think this is because people are not interested in joining. I think there's been a technical glitch, but the message has gone out. I understand that the glitch has been fixed, fingers crossed. So with a bit of luck, more and more people will be joining as the session goes on. So we hope that those of you that are on the course at present, that the course will meet with your expectations, and that you're going to enjoy it. It's a wonderful topic, very important topic, and I know that Dr. Pradeep has a good way of conveying his knowledge and the insights. So I'm sure we are going to enjoy it. So as mentioned, we have an expert on the subject as a course instructor, and that's Dr. Pradeep Kumar Srivastava. And let me give you a quick background to Dr. Pradeep. Dr. Srivastava is a former head of the Division of Entomology and Vector Control in the National Vector-Borne Disease Control Program in India. He was also co-chair of the APMEN Vector Control Working Group until March 2021. And that's where we started working together. Dr. Srivastava obtained his doctorate in 1984 on insecticide residue analysis from the University of Allahabad. He was the India Nodal Officer for elimination of lymphatic filariasis from 2004 to 2016. So he's not just a malaria vector expert, it goes wide. Sandflies, filariasis, and others. He's been an advisor to WHO on many occasions for the elimination of lymphatic filariasis. He's also been the recipient of a Vestergaard Franson Award in 2019. Dr. Srivastava supported WHO in preparing several strategic documents and also the Vector Control Needs Assessment document in 2020. Most recently, in 2022, he prepared a national plan for insecticide resistance monitoring and management for Bhutan with the support of APMEN. And he also formulated an integrated vector control strategic plan for Timor-Leste in collaboration with WHO. He has worked with the WHO for a recent assignment, Malaria Program Review 2022 in India. So he's got lots of a lifetime's worth of experience, including very recent exposures to current trends and so on. Just some quick housekeeping issues, if you don't mind. I'll keep it short. As a reminder, instruction will be given probably for about 1.5 hours each afternoon from today until Thursday. And then after that, roughly 1.5 hours of training. There'll be question time after each session where you'll be free to ask questions, which hopefully someone can answer. Half of you, which is all we can really manage on this Zoom platform, are enrolled as panelists, as explained before, which means you can simply turn on your video and audio at any time, whereas the others, unfortunately, will need to post a message in the chat box if you had to have a need to go live or video. We encourage you to post questions in the question box, please. Not the chat box, in the question box. That's the box we'll be monitoring, which in the Q&A session at the end of each day, we will pose to Dr. Pradeep. Please also know that only those that attend all 4 days of sessions will qualify for the certificates of attendance. And finally, at the very end of the course, we will ask if you wouldn't mind filling in a short questionnaire, giving us feedback on how satisfied you were with the course and how we can improve it next time around. Dr. Pradeep, thank you again for your willingness to present this course. We're sure that you will find a very receptive and attentive audience, and we genuinely appreciate your time. Thank you, Dr. Pradeep, and now over to you.
Thank you, Dr. Leo. And good morning to all from India. Good afternoon for everybody, those who are joining from different regions. I am also very, very happy that so many people, they have shown the interest, but still I am seeing the message that many of the senior people, they are telling that their colleagues are not able to join. I think your Ulan and other people, they will try to set right the things. Thank you. Let me share the screen so that we can start the session. Is it okay? Is it clear?
Yes, it's good. Thank you, Dr. Pradeep. All clear.
Yes, it's quite clear.
Okay. So now, thank you, Dr. Mukhtar, and I'm very happy to see all of you, all my friends, Ghosh and other people, and Dr. Mukhtar. In fact, yes, we told that it's a long time we have met physically, but anyway, some conference someday we will definitely be meeting. Thank you. See, the basic philosophy which we all were interested, and I mean, whenever I have been doing the vector control need assessment and strategic planning, and recently in India also we had a malaria review for visiting 6 or 7 states, and then 3-4 states on the desk-based review. And then we had been recently to Timor and other places. So, I mean, different places, people, they have got a different kind of scenario. And the basic thing is that aligning with WHO guidelines, what I personally feel that the basic challenge in public health program personnel working in the field or working at the policy level, because of changing scenario, transfer policy, retention policy, there are so many things. So updating of the knowledge is not to that extent. Otherwise, the guidelines are perfect, but somebody has to continuously explain them. So we thought, and we have been talking all this, and thanks to Dr. Leo and APMEN and APLAMA that they have started this course. So basically, how to make, what exactly we understand with the strategic planning, what is the difference between framework and plan and operation manual and then SOPs, and then ultimately start from Geneva until some of the village level, how it works. So this course has been divided into 4 parts. So today we will be talking on what is the strategic planning basically for malaria vector surveillance and the National Malaria Elimination Control Plan or Elimination Plan, and then Vector Control Plan, where does it fit? And then tomorrow, I think we'll be talking about the Vector Control Plan, strategic planning, what are the components. And third day, it will be on basic tools and technology and how it should be operated into different situations. We are going to have many situations. And then finally, we will be concluding with how to formulate the physical planning into the financial planning, monitorable targets, what are their significance and other things. So basically, it is a complete package. And for that, I'm very, very thankful to Dr. Leo and team and the APMEN and APLAMA. So let me start with the first slide. The basic, I have divided this presentation into the concept, the framework of the planning, then the strategic plan components, and then the vector control planning, what is its significance, and then what are the components. So today's lecture will be restricted on these 5-6 topics. So when we talk of the concept is not new. Basically, the concept is not new because we started long back. And the first manual was released in 2007, and prior to that also 2002-7, and then we have been talking about the control. And if you see the earlier literature about 50s and 60s, we have been talking on the control, attack, consolidation, maintenance, all these phases. The same thing has been now in a revised manner. It has been given a different categorization. The only change we have done on the basic structure is that it is not only on the epidemiological criteria which we were considering on the reducing the annual parasite incidence, malaria incidence precisely in the high burden zones. And then when we see that, yes, it's a cutoff point. Initially, it was taken API 2, that is 2 cases per 1,000 population annually. And later on, it was reduced to 1 case per 1,000 population. There is no justification for that. Scientific. It was just made in 50s and 60s on the resource availability, and there was some criteria was to be fixed, because if you calculate the API 2 means 2 cases per 1,000 population in a year. So 12 months, if you are getting in 1,000 population 2 cases, you can imagine that per month how many cases it will be, some in points. So that was consideration was there. It is all written in the old undocumented, unpublished literature. But now what has happened in the 50 years, what we have reached to the state, remarkable success, just like Amita was telling, and the World Malaria Report every year what is published that says that yes, malaria is going down, except the last year report which has shown little bit increase. So what happened that we have to change the criteria, and when we have to change the criteria, we definitely needed that what epidemiological criteria has to be fixed. So that criteria in different scenario has been fixed, that it is not the epidemiological criteria only, but it should be case based. When the number will be less, it should be on the absolute number based, and then other situations, other parameters will be taken into account. So this is what the basic concept change. Slowly we are entering into the before we reach to the elimination, we have controlled almost, we have consolidated, we know the situation baseline into 2015-16, somewhere they started 14-15-16, and then we have made a 5-year plan, which we'll be talking later. And then when we know that the cases are actually reducing, and many of the countries, the cases are very, very less. So when the cases are less, there is no justification for the parameter of annual incidence. With this background, what are the principles? What are the principles of the total framework? When the framework was designed, framework is basically how you make a plan, in what segments, what idea should be there. So when we are talking of some principles were taken. The first principle is that the country, if they are actually signing or they are giving a commitment that yes, we are going for malaria elimination. Elimination is basically zero indigenous cases. There should not be any transmission. That will come later. So the first is that we should own the responsibility, and our leaders, they should give full commitment and their involvement should be there. And not only involvement on paper, but it should be with the participation of the committee, because they are the public leaders. So they should take oath, they should give their commitment, show their commitment with the people. Then they should also advise that how elimination efforts should be accelerated. And then accordingly, the different functionalities at different levels, they should make a plan, which should be basically, we have been talking on malaria as a local and focal disease. So it should be basically local context should be taken into consideration. So the one strategy which we have been making from the central level in any of the countries, calling people technical experts, then making the guidelines, the framework, and then giving the advisories, and everybody has to do it. We have been talking that the program is run by rule of thumb, but now the situation has changed. The program will not run by rule of thumbs. Broadly, yes, it will run by rule of thumb, but we should give a flexibility. We should try to accommodate the local context, because we have seen many changes at local level, and it will save a lot of resources. This is very, very important principle of the making the framework plan. And then we should also see that whatever impact is visible, whatever improvement is there, it should be evidenced by the data analysis. Data should not be only for the reporting purposes. And once the data is analyzed, we should go on doing a stratification. Stratification is also not once that was okay, 2015 we have given a commitment and we have done on stratification, and then we are slowly saying that. No, stratification should go on yearly basis, so that if there is a need, we can switch over on different kinds of intervention. We can reduce interventions or we can increase certain interventions. There will be some fluctuations in some areas. Then there is a saying that once the caseload is come, the public health approach will be little reduced, but not to reduce that public health approach, vertical services, special services, the health services, general health services should incorporate that, and this should be accessible to everyone. All the people, community, they have got the right to have the access to approach them. So the health services quality should improve, quantity should improve, all the programs, all the diseases must be included, accessible for everyone. And then the last but not the least, that interventions, traditional interventions always go on improving. There are a lot of innovations have been done, innovations in terms of technology, innovations in terms of tools, innovations in terms of new insecticides or drugs. All these things are to be incorporated, and then a good health system, a responsive health system, which is accessible. It should not shut their doors. It should not do any discrimination. That only will support and sustain and maintain all the success whatever we have achieved. And that is what I remember 1977. I mean, just to give an example, one line that when India had a resurgence of malaria in 76, 77, the plan, modified plan of operation, one point was emphasized that what was the objective? To sustain the gains achieved. So that is what is, if resilient health system will be there, it will support the success gain to sustain. Now, a lot of brainstorming has to be done on the elimination, and then the basic concept which WHO came out for the global elimination, that was, I mean, in 2017, when the global vector control response and the framework of malaria elimination, all these things were released. See, all the endemic countries have to be included. initially there was some changes. I'll come back to that. Then basically the actions were highlighted. What actions are required from high burden area, high malaria zone area, how to bring to the low endemic area or zero endemic. Overnight it will not come. It will take some time. So that is why there was a categorization, stratification that you bring, and that stratification has to be done in local situation. African stratification will be different than Indian stratification. Timor stratification will be different than Indonesian stratification. So the high level critical point, the last point, suppose API is more than 10, API is more than 50, API is more than 30, that should be taken, and then the lowest mode. Then you can divide the whole area, how it should be stratified and what fragmentation has to be done. Initially, it was thought that those countries who will be eligible, who will do the feasibility, where elimination is feasible, they should be. But no, now that feasibility problem has gone, because all the malaria endemic countries have been included, because it is a global elimination campaign. So all these critical requirements, what is essential to achieve and maintain the elimination has been included in that. This is the basic concept of this framework. Information system has to be very, very strong. If information system is not strong, the whole surveillance, you are doing some work in the remote area, in the farmost area, if that system does not catch those things, you will not get the actual picture. So the information system has to play a very, very critical role. Then every year, once you reach to certain state, you see the impact. What is the next step? What is the next step? That is also defined very categorically in the framework. Rapid diagnostic test was an innovation, not an innovation, rather it is a revolution of after light microscopy. And both the tests, RDT and light microscopy, they have been recommended, and they have got proper place where initially first you detect all the cases, whether you through rapid diagnostic test. There have been some kind of differentiation that where RDT is to be used, where RDT is not to be used, whether microscopy is to be used, or whether the combination of both, or RDT followed by microscopy. So all those things have to come very categorically in the plan. Then for surveillance, once you reach to vector control, before reaching, you must know what is the magnitude. So another strategy of mass screening and test was also included, so that the asymptomatic or the hidden carriers, they are also captured, so that you know that this is not the situation only based on the reported figures. The reported figures or the assessed figures may be a little more different. So you have to put a lot of other preventive tools. Then the framework also talks about the certification, which is little more simplified. Not so many complicated things are there. It is very, very simplified, that there are different steps. You do this, you do this, and you do this, and then finally you come back on the certification process. And then basically the re-establishment of transmission, the threshold was clarified in this framework. What is this framework now? So this was the basic concept. It looks little more complicated, but I have tried to make 15 slides into one slides. Basically, if you see, if you want to achieve malaria elimination, what are the principle and practice? We must understand what is malaria transmission going on in that particular area, that particular province, that particular country, by and large. Like, for example, if you say malaria, I can just compare two places where I have been more vigilant. Like Timor, there is only one vector complex malaria transmission dynamics by Barbarostrix. But whereas in India, if you take, it is a 9 vector, and some people, they say it is a 10 vector complex. So malaria transmission has to be understood properly. Second one is whether we are targeting with global elimination, and what goal date we have given, what goal year we have given, whether we will be doing only in 2030, or we have fragmented it. Some states will do 25, 22, 27, 26, something like that. So accordingly, we have to align our target to ultimately reach to the global elimination. So with this principle, we should start our practicing. Then we must understand what are the strategy. The second component of the framework will be strategy. Whether we are fully equipped with the strategy, whether we are aware about this strategy. Strategy will start with the stratification. As I have been emphasizing, stratification at different years, different area, national level, state level, district level, sub-district level, even up to the go. If your system is very, very strong, you can go up to the village level. So that narrowing down the focus will be very, very easy by the stratification. Then after stratification, we will restricting basically on vector control. So we will highlight only vector control, but other things are also there in the framework. Preventive things are enhancing vector control. Vector control, when we discuss in detail. Then there is a case detection and management. It's basically two pillars. Either you detect the parasite and treat them in the human beings, affected people, or you start preventing or controlling or containing or reducing the transmission, interrupting the transmission by reducing the vector or reducing their longevity. Both this, either vector control measures or the case detection management, quality assurance is very, very important. Quality assurance in terms of logistics, quality assurance in terms of quality of the goods at the time, right from the purchase time, specification time, till last it supplies, its efficacy, its shelf life, its implementation. So that is about the logistic, but quality assurance simultaneously we have to maintain at the performance level also. Whether the people are trained, whether they are doing quality spraying, whether they are doing quality monitoring, whether they are doing, I mean, so the process quality is also to be monitored. It can be monitored by cross check. It can be monitored by random sampling check. So there are different ways to do the quality. Then only the quality assurance program will run. Then for both these things, vector control and case detection management strategy component, we have to have a very, very strong surveillance. Whether you talk of epidemiological surveillance, whether you talk of entomological surveillance or vector surveillance, this has to be very, very strong. Either of the pillar, if it is not equally going, the whole vehicle will tilt on one side. And then you will lose the data, you will lose the evidence, which cannot be repaired or replaced at a later date. So we have to be very, very cautious about the maintenance of the surveillance system for both the pillars. And then after the surveillance, what activity needs acceleration? How we can accelerate and then achieve this malaria elimination? Then again, you will reach here. Then once we know about this whole strategic component, the yellow marker, then we have to see whether our management and planning, where to go, how to go, what direction, how it will be planned, when it will start. That guidance is required by the expert. So the first is that at national level, there should be a very, very strong members committee should be there. There are many places it is there, but whether it is meeting regularly, it is really advising, or it is just on a paper base. It's not for holding sake. It should be for achieving the elimination. Then according to that direction, the planning process should start. If you know your transmission dynamics, which I have told first is understanding malaria transmission. If you know your transmission dynamics, somewhere it starts in June, somewhere it starts in April, somewhere it starts in February. So according to that, your strategy should be implemented. And how your strategy will be implemented when you do the planning, whether you have to start your implementation from January or February, I mean, which month of the year you should start, you should initiate the process. Then if there is acceleration needed in different scenario, what actually you have gathered the data, analyzed, and what is the decision based on the information received. So whether that decision is informed decision or it is just a tentative decision or anticipated decision. This is very, very good. This is a part of the planning document. So this is a part of the framework. Supply chain, I have already explained that supply chain also a part of whole planning management, because your supply, your logistic must be available before you start the strategic implementation. Otherwise, you will start and then you will say that LLIN has not reached, or insecticide is not there, or the pump is not there, or pump is repaired. So that supply chain has to maintain, that chain is to be maintained, so that, and to ensure that they are in right time. And what is the structure? Infrastructure is very, very important. Without hands, you cannot do the work. So for performance, you need a very solid, strong infrastructure, which you can tell in terms of human resource, in terms of financial resource, infrastructure in terms of your accommodation, working atmosphere. All these things are very nicely has to be depicted in this framework. Whether you talk of vector control or you talk of any activity, you can talk a micro activity. Say, for example, a vector control, if you say spray, what is the structure available in the PHC level, primary healthcare level, or this sub-center level, or the district level, where the stores are kept, when the people will come for the spray, when their training will be there, where the place is available, what kind of material. So these are all the part of the infrastructure. So that is how we enable and enabling environment is another important issue. Enabling environment does not only tell a good building. Enabling environment is there should be opportunity to work in a harmonious manner. You should be equipped, you should be fully equipped, you should be trained, your skill, your working place, your working environment, your mobility, everything should be very nicely. And all the time there should be in the mind that yes, we are working for malaria elimination to achieve this. Once we know these three things, then we have to come on we will see the achievement, we will see the dent. And the last point of this framework is, once you have achieved the less number of cases, or suppose you have got the no indigenous cases, then how to stop, how to prevent its re-establishment. Because everybody, most of the countries, they have burnt. I mean, India, definitely we have burnt our fingers that we opted for eradication, and we reached to the level, and then again there was a resurgence. So we don't want to go into that scenario. So what are the risk elements for prevent re-establishment of malaria transmission? That is why the first lesson was understanding the transmission dynamics. Once we understand what are the things responsible for risk, for re-establishment, and then how to prevent it. Now, once we know the risk and risk prevention strategy, which is very clearly explained in prevention of re-establishment, then we have to tell our health system that health system should be maintained, because the cases are very less. So what are the things required? We will come back on later. This is only the topics. And then later on, we have to integrate with the general lesson. Look here, we have achieved this, we have shown this, these are the risks, you have to do like this, and then how it has to be function properly. So you should not forget about malaria, you should not forget about microscopy, you should not forget about use of RDT, you should not forget about spraying, you should not forget about this LLIN, because most of the people, they say that once the cases are gone, spraying is stopped, you have to forget about spray, you have to forget about LLIN. Lot of questions are being asked whether LLIN should be supplied or not, and how much, so much quantity, because there is no malaria. So these are the things. Then the certification process will start, and it is very simple that bigger countries, they have to go for subnational verification slowly, because in one go, the whole country, say for example, India, so many states, so many union territories. So at one go, it will not be done. So it has to be, stratification has to be done, and then subnational verification at lower level, the verification should start. And that responsibility should be given to the local people. There is a set procedure for that subnational verification that is given in framework and the guidelines. So they should go for subnational verification, and then they should submit, including the vector control operations, whatever they have done, whatever process they have done for case detection, both the pillars, vector control and case detection, and then they should follow the WHO certification process. They should submit to their respective heads. It will come to the national level, then they will supply. Once the whole country, all the places, subnational reports are there, it will basically to help to support in a phased manner to reach to the certification process. One very important point which I would like to tell, that is a practical experience, that those who are achieving at subnational level early elimination, they have to sustain for a longer period. So that is a big challenge. And then support from research is always continued. Research will be during this period also, during innovations, new technology for vector control, or for the like RDT and all those things. And then operational research will also continue. Operational research will go on giving support, different techniques, different I mean the diagnostics are coming up. There has to be regulatory environment for malaria elimination. That look here, once we have achieved, you have shown this POR must have this and regulatory environment for malaria elimination for the researchers, for the operational research, for the states, for the local bodies, everywhere it should be there. So this is what I just wanted to explain in one slide, which is actually a mix up of 4, 5, 6 slides. Now, this everybody knows that some of the slides we have taken from WHO framework, that global technical strategy. There are basically 3 pillars when this was decided that 2030 will be the target for malaria elimination. What is this 3 pillars and 2 supporting elements? Basically, the first pillar is universal access to malaria prevention and diagnosis. I mean, can approach. Then our services should not be restricted, because we have been stratifying in high burden, middle burden, low burden, lowest, very low. I'll come back to that. Then the second pillar is basically our efforts towards acceleration. And third is most important. That's why this whole course is designed, that transform malaria surveillance into core intervention. Malaria surveillance does not mean only epidemiological surveillance. Malaria surveillance emphasizes both the pillars on same footage, epidemiological as well as entomological, or you can say vector surveillance. Now, the 2 supporting elements, that is innovations, harnessing the innovations and expanding research, and the second one is strengthening the enabling environment. What is that basically? These are the 3 pillars when we are talking of transformation of malaria surveillance. And what is the supportive elements? Basically, it enhances. Research can be divided into basic research. Basic research, this is basically to invent something in the lab, development of new techniques, new interventions, new diagnostics, new testing procedures. So many things are going on across the world. Even those countries who are not malarious countries, they are also coming forward because of their resources available. They are doing wonderfully well, and then they can get the field in the malaria endemic area. The only challenge for basic research to go to the applied research and testing will be, once malaria goes down, it will be very difficult to get a proper field. I remember in LF elimination, when this diagnostic test kit came, they wanted to test it where the cases are load is very high, but there was no case found, so it could not be tested in India. They went somewhere else. Same is when the research is taken from the lab to the field. Before that, its cost effectiveness, before it is included in the program mode, because at a larger program, public health program, cost is very important. Whether this is within the pocket, within the resource availability, or it is something like asking for a moon. This is very important. And then if everything goes well, then how to uptake the new intervention? Who are responsible? They need to be sensitized. This is what is supporting element. Otherwise, everybody is sitting in their own chamber, and then nobody has approached, nobody has talked. So these are the things which will be having a nice framework plan, so that this particular third point, that who will take this, where it will be taken, how it can be expedited. Then the second supporting element is enabling environment. I have already told something, but strong political financial commitment is the first resort of enabling environment, because unless there is a wish, there is a wish, there is a commitment, there is a desire, and then there will be accomplishment. Then multi-sectoral approach. You cannot, one person cannot do. So we have to take, because malaria is though local and focal, but it involves so many things. That is why the challenge is so many parasites, so many mosquito vectors, so many people, so many sociocultures, so many social determinants, so many migration, so many factors are there. That is why collaboration at different level and accountability and responsibility. And once you take more people, you have to tell them, look here, you have to do this, you have to do this, you have to do this. So their roles and responsibility has to be clearly defined in the plan. Then who will take the stewardship? Entire health system. Again, we have to struggle with the vertical system and the integrated system. So what will be the regulation? How the regulatory support will be governing that? Basically, it's part of governance when we talk of the enabling environment. Better governing state, better governance state can perform faster. And if the governance is lost, if the stewardship is not there proper, then the whole system will not function to the desired level. Capacity building is very, very important at different level. Who is to do what? We have to sensitize. We use 4-5 terminology for that. We say training for the students, training for the participant, training for the grassroots level, but we don't use word training for the society or for the people who are at the local. So we call it as a sensitization. Either higher level, we call it as an advocacy. So these are the different terminology we use, and we have to be very, very careful when we are using this supporting element too for this. This was initially targeted, that global strategy they have. This is another WHO slide. I just wanted to highlight this, that when it was started, then initially we thought that at least 35 countries, these are the target what we should reach malaria mortality 90%. We have almost reached to these people, these things, but 2020 we have not reached 25 and 30. But what we thought that at least 10 countries, and yesterday I was just going through 21 report. After this, 9 countries have been eliminated, if I'm correctly, I have understood the World Malaria Report. But there are many, many more countries, 40 countries or something like that. But they have all eliminated before this GTS came out. So once we talk of this 21 report, we have achieved, because there is slight increasing trend shown in the 21. So let us see hope for the best by 2022 reports. So these are the main targets, different years, 5 years, and this 5 year is very important. That is why this 5 years business has been taken, that initial planning is being done for 5 years. Now, this is another important, when we are making a plan, which setting we are targeting. First one is all countries, then concept of elimination replaced with the critical requirement. Now we are setting the targets in different states, different areas in a different time bound manner. Like for example, if I give the example of India, we have divided into 3 categories. So some are targeting by 25, some are targeting by 22, some are targeting by 27. But last 3 years we have just kept for sustenance period, so that if there is a buffer period, so that we can sustain. And that also for certification also it is very, very important that we have to, 30 is the ultimate goal. So our all these settings must target 3 years before of 2030. This is the only important message from this slide, that which setting we are targeting, and we must target all these settings by 27. This is very, very important. Now coming to the another important point, what is the strategic plan component? Now again, as I have been telling, that we must understand before we go for the component, that what are the components. Basically, when we started designing the framework in 2007, feasibility of elimination, limited countries based on feasibility, classification criteria, there were 7 focus, and there was a elimination strategy with the control to elimination. But now in 2016, the GVCR and another framework which has come out, they come out with that it is critical for all the nations are included. Process monitoring has been very, very stringent and emphasized in this new framework. Simplified focus classification, it is not 7 now, because case classification has been separated. So the simplified focus classification is only, there are only three, basically. It is active, non-active, residual, or it is cleared one. Now, there is flexibility has been given in program implementation for the framework for the different countries with the changing situation, which was not earlier seen in that the old framework. Different transmission intensities, their strategy can be changed. That will be part of this maybe by tomorrow, because this is very, very important strategy for different transmission systems. So when you mix both these things, what are the basic components of this framework? Then we have control to elimination. We are consolidation. We have already reached almost many of the countries, they have reached to the consolidation, except few in African countries. So we are reached to the pre-elimination. Now we are targeting for elimination. And then by after 27, we will be in the maintenance. So these are basic components for the framework, which we are targeting for designing the whole plan. Now, when we talk of malaria elimination strategy or the components, we must understand what is definition given by WHO for malaria elimination. It's basically, as I told you, that zero indigenous. There should not be any indigenous case. Indigenous case means local transmission should be interrupted completely. Then only the question will come, prevention of re-establishment. Re-establishment will be only by either by some cases coming from outside, either imported or induced cases. So that has to be prevented so that local indigenous again does not establish. This is the basic definition by the WHO. So keeping this malaria elimination definition, we must have a, when we start framing. Now, this is just an example, the transmission intensity for malaria. I mean, in basic country like country like India or country like Timor or country like Indonesia, now we have crossed this high endemicity level. Maybe in one or two pockets it will be there, but it is not there. But basically, when we decided that transmission intensity, if there is a high, there should be different strategy. I mean, all the tools you have to implement. And when there's a little less, you can go on excluding one or two. Slowly, when we go on the lower intensity, 100 or 250 cases per 1,000 population, even this is not there now. So you are entering into a very, very low cases, 100 cases per 1,000 population. But if you are entering in zero, what exactly you have to do? So different transmission intensity, different strategy has to be followed. And this is what is stratification. That once you look your stratified maps, you will be able to know whatever range. The range may not be from 100 to 450. The range may be maybe 2 to 10. The range may be 10 to 50. But you have to divide your whole range into different category. This is the first point of the framework making a strategic plan. On the after this only the vector control will start. And the very, very important slide, though I have taken from WHO, if you see different strategy for those 3 pillars and 2 supporting elements, you see the first category has been given, importance has been given, category A. If you see, enhance and optimizing vector control. This is the first important point. It starts from here. Once you have stratified for the area, the first strategy is the component A. So vector control is the most important component, and that is what it signifies. Then you have to go on doing the cases, surveillance, and then go on detecting them, give them treatment, whatever is recommended treatment are there. Then you have to go for assess your surveillance system. Are you getting the same thing? Are you able to locate the foci or the endemic area? Earlier we were calling endemic area. Now the area is restricted. So whether it is an individual case or it is a foci based group of cases in some area, narrowing down, and then you are characterizing the case, whether it is indigenous and whether your surveillance system is able to capture all these things. Otherwise, for the last 50 years, we have been trying. Private is different and public is different, and we are not getting. So these are the challenges we have been listening for a long time. But unless your surveillance system will be strongest, you will capture everything. And for that, regulation is very, very important. Then entire population is cleared by parasite. or new interventions you have added, or it is required, either applicable or not. That becomes the third component, and slowly it becomes the fourth component, that if the cases are one or two or no case, please be vigilant so that you can have an eye on that and you can follow up all the cases, because if more number of cases are there, you can't follow. So the basic concept is that the most important component of our whole strategic plan is vector control. This is what is that. A is enhancing and optimizing vector control. The B is increasing the sensitivity, accelerating transmission reduction, and then investigating all the cases. That's what I explained. Now, once you start achieving this is also a WHO strategic planning, but this is very, very important for to be understood by all the people who are working in the field, that once we are stratifying, it's not a general stratification based on the API or the malaria case incidence. No, it's not that. It is basically when we achieve certain targets of from pre-elimination control to pre-elimination to elimination, then what is the state we are expecting, or this is a fact that heterogeneity of the area will be there. There will be some area where there will be no case. There will be some area which will not be receptive for the mosquito breeding. There will be some area where the population will be vulnerable, or it will not be receptive. So take one point of receptivity, which is basically one of the very, very important factor for risk. When I was showing that map, the different principles, then there was a POR and then there was a risk factor. After achieving Narayan Swami, your phone is, please, Narayan Swami, please mute your phone.
Dr. Pradeep, can you hear me?
Yes, please.
I'm sorry, the people, may I ask the general audience, please mute your computers. Also, how are you doing, Dr. Pradeep? Do you think it might be useful to give yourself and maybe the audience also a 5-minute break? And then we resume, just for people to stretch legs and go to the bathroom. What do you think?
Okay. I'm absolutely fine.
All right. Shall we take a 5-minute break and then we start when you're ready after 5 minutes, Dr. Pradeep?
Biological break. Thank you.
Here we are. Okay. All right, everyone. Stretch your legs for 5 minutes. We rejoin again. Thank you.
Thank you.
Thank you, Dr. Pradeep, for wonderful. And after 5 minutes, we'll be there.
Thank you. Thank you so much.
Hello. Hello, Dr. Leo, sir.
Hello, Dr. Pradeep. Are you back?
Hello.
I'm not
Yes,
sure.
sir.
I didn't actually keep
back.
track of time, but I think 5 minutes have passed. Is it?
Okay. Okay.
Yeah.
I'm ready.
So let me just say, Dr. Pradeep, you're doing a great job. It's coming across very well. You're creating wonderful context and indicating all the elements and processes that we should keep in mind as part of the strategic planning process. So you're still creating that background, which is extremely useful, and you're explaining it very clear. I'm hoping everyone will agree. And I think even for our more senior people joining us, it's very good refresher course for them as well. And hopefully here and there new lessons. But I think everyone is solidly behind you and enjoying your presentation. You're doing a very good job, Dr. Pradeep. Thank you for that.
Thank you very much. Thank you.
Yeah. So back to you, Dr. Pradeep. Continue if you're ready.
Okay. So this slide, thank you very much and welcome once again. And I appreciate if something can be taken from these my lessons. I'll be much grateful, and I'll think I'll pat myself if something is taken to the field from after this. The slide is visible still.
Yes.
Yes, no problem.
Yeah.
Thank you.
Thank you. So I was just describing that once we reach to the very low level, which we are almost entering to that area, maybe next 2-3 years, most of the countries, they will try to come, because most of the countries, they are also coming that. And once we try to stratify the area, we may encounter, I'm not taking now the epidemiological things, because epidemiological, we have discussed many things. Now we have to go for vector control. And before we take the vector control, we must see what is the risk factors. So whether the area is receptive in terms of vector breeding, receptive in terms of vector prevalence, receptive in terms of the vector potential. So we have to stratify the area. This is a little difficult job, because receptivity and vulnerability, the parameters still at WHO level, it is being debated. And hopefully I'm expecting that by December, the another guidelines will come back. So this non-receptive, we will enter into so many stepwise figures. There will be one non-receptive and receptive area. Then we will learn further that even the non-receptive area is increasing, maybe because of constructions, because of good protection habits of the people, site changes. But there will be some receptive area where there will be no malaria. Like I can give some example, like top of the hills, if you go, even with the climate change, they are becoming dangerous for the mosquito breeding, but there is no malaria indigenous transmission. So there is no malaria cases. So all the three things earlier we have been tried malaria transmission. Now there is a fourth one. One is the parasite, then host, then vector, and now there is a climate. So these four things, if one is not there, especially the vector and parasite, transmission is not possible. So we have to classify that the area receptive, but without malaria cases or malaria, and there is some receptive area where some malaria transmission is there. Maybe one case or two cases, but if it is proved indigenous, that is based on the vector surveillance entomological parameters. This is very, very important stratification. And then we further entered, in addition to the third one, we may find some malaria foci which we eliminated 2 years before or 1 year before. There are suddenly some new cases have come and that is established as an indigenous cases. We may end up in that. So we must enter, but it will not be the whole area. We have to identify the case, maybe the house, maybe one village, maybe one hamlets. So we have to identify. That is why this 3-4 things are there. And then the another category will come if this is their malaria active foci, but in that some will be cleared immediately because of our action as per our plan. So if that by either by case treatment and by vector control measures, if that is cleared, so then the classification will go further that in addition to these 2-3, there will be the classification of this foci that you see, this red color has been made as a white color. So this foci is cleared, but these are, and this is part of the foci is cleared. So these are the area still active foci, but the another one is coming as a some low transmission area in the malaria without the defined foci. So there are risks. And these risks only has to have the degree of intensity of the transmission. So we have to be very, very categorical that which this kind of stratification will help us in taking the vector control. And when we talk of vector control plan formulation tomorrow or day after, then these are the areas which will be taken, at which activity will be done at what kinds of situation. This is what I was just telling, that old classification was 7. I remember sometimes LF that there was 7 grade of lymphedema and now it has been reduced to 3. See here also, see active foci, residual, non-active foci, cleared foci but receptive. That's what I showed in that map, and cleared foci but non-receptive. And these 3 has been taken as a case classification or characterization, that indigenous case, imported case and unclassified case. Earlier this was all their part of the foci. Now these 3 red colors have been taken as a separate, as a case characterization. Based on that, we conclude about this 4 category of foci. This shows the map which I showed, stratification map based on the receptivity. This map shows, this is very, very important, that one major uniform measure or one size will not fit for all, like Taylor Master also when we say this is a coat. So one strategy will not work for every place. This is very, very important. And when we go for vector surveillance, entomological surveillance, sociological factors, all these things will be part of our strategic plan. Because once we take the framework, this is basically a guidance document for making a national strategic plan. So stratification of transmission intensity, then about the knowledge, good understanding. That's what I told in that map also. The first is principle, the malaria transmission dynamics. Epidemiological, ecological, and social features have to be understood very, very clearly, because most of the places social determinants are not taken into account. This is now it is to be taken into account, and people must understand that what is the relationship of the social determinants. then intervention should be adopted according to that locally, because this is a code which will fulfill here. So we have to plan our entire vector control or intervention measures according to the requirement of that particular area. If certain area doesn't require LLIN, don't promote for universal coverage of LLIN entire district. You say that this particular area only can be LLIN will be working. This area will not. I'll come back to that. I'll come on to that. Another component which I was explaining in that original graph, that subnational verification of elimination, which will be very, very important building block. I have already explained that basically bigger countries where national level will be little difficult or little cumbersome to combine all those things. So if smaller units, they give us support that look here, I have reduced. You have seen in the receptivity map also stratification that if some area becomes white, there is no harm in getting a verification process done and then enter into the maintenance phase, so that our focus attention of the national authority or the state authorities, governing bodies, that will be more on the high burden. And that is what the high burden, high impact principle says of the WHO, that in focus more on high burden area so that you will get high impact. Once you receive the high impact, you bring down to that level, then you go for the pre-elimination, then you go for the elimination, then you go for the prevention of re-establishment phase, and then consolidate maintenance phase. That is what the whole process goes like that. Application process will be very, very easy, because once you make a strategic plan, this component is the last component which must come in your strategy. That we must understand how to certify, because everybody will talk that we have reduced to below 1 API, so we have reached elimination. No, it's not that. So we have to reach to the POR, we have to ensure POR, we have to documentarily prove POR is established there. We are able, our surveillance system, vector surveillance and epidemiological surveillance is so strong that even if one case, immediate reporting, immediate catching, immediate attention, and immediate liquidation of that foci or that particular case, then we can go for certification. This is basically 3 years is very, very important with zero indigenous case, because this is the requirement of the WHO, and this will be submitted. The formulation certificate by the country will be submitted to the certification elimination panel of WHO. They will send it. If they satisfy, they will submit to Malaria Policy Advisory Committee. Then Malaria Policy Advisory Committee, they will maybe assess, they will recommend whether it is to certify now or another some more time is to be given for that particular. Now that Malaria Policy Advisory Committee, once it convinces itself or its member, then they will recommend to WHO Director General, where they will make a final decision, and then the country will get the certificate. So these are all some 6 or 7 steps which everybody must keep in mind. They should not be misguided that they have received 1 API less than 1, so they have achieved elimination, and why certification is not being issued. This is very, very important part of the strategic plan, whether we make it as a national level, we make it a state level, we make it a subnational level. Now coming to our basically, so these are all the components of the overall national strategic plan with the background. Having understood all these background of the national strategic plan, we must make one vector control plan. As an entomologist, as a vector control specialist, we should be able to guide one full chapter, what will be our role. So vector control community, because this is very important. I showed you the A category. Before we make the vector control plan, this I have been explaining many of the times, that vector control plan requires support of both entomologist, full-fledged entomologist, and the vector control specialist, vector control expert. Now the role of entomologist is to do the vector surveillance, entomological intelligence. They have to use in the data interpretation. They should be able to do the correlation or epidemiological, entomological, social determinants, and the receptivity, vulnerability, geographical, ecological. Then they should be able to advise in the planning. Policy makers. so that policy is framed. And then they should be able to monitor its impact and evaluate what they have suggested, what is being implemented, whether this is being assessed, and what level we have reached, whether we have reached to the desired level or still there are some changes required. So this is basically a job of the entomologist. Vector control experts, whatever comes to them available within the available resources, they must implement those tools. So they must understand about the tools and technology. They must have the proper logistics. They should be competent enough to supervise the actions required by them. They should be able for spot supervision and guidance in the field itself. They should not go back, okay, tomorrow I have seen this thing and I will go back, let me go back to my headquarters and then I will. They should be competent enough for field guidance. And then they should report, because ultimately their report is only will give an indication whether we are doing process correctly and then what is the impact on that. So my issue is that before we make the plan, there should be vector surveillance plan and there should be vector control plan. So this is very, very important and both are linked together. So again, in vector control, both the pillars are very, very important. Any entomologist can become the vector control experts. So all the entomologists can become the vector control experts. Well, all the vector control experts can be a public health engineer also. We had one position of public health engineer positions, or the biotechnologist, or fish experts, or the society experts, or the social scientists. They all can become the vector control experts. But all vector control experts cannot become a pure entomologist to the vector monitoring, vector surveillance, vector intelligence. So this is the basic difference we must understand. So this also should have, like national strategic plan have two strong pillars, epidemiological and entomological. So the vector control plan also have two pillars, one the vector surveillance and the another one is the vector control planning. With this background, if you go through the vector control plan, what is the vector control plan? What it should include? Whom it should go? What are the inputs required? How it should be implemented? And what are the measures? Then only we can expect some outputs. So vector control plan, first thing is that what policy, what commitment, what advocacy, and what evidences we have got in our hand based on our historical data, based on our collected data, our trend analysis of the disease, our situation analysis. This is very, very important. This vector control plan will make a part. Similar things will come for epidemiological also. Similar thing will come for the governance also. Something will not come. So once we know that, then we have to, who will do, with whom we have to make this plan? Entomologists, vector control experts, even policy makers and implementers. We should take all the four people into cognizance on the same board so that we can make our vector control plan meaningful, feasible, doable. Then our inputs will be, this is the 4 points which will come in the vector control plan. What are the resources we have? Resources in terms of human resources, financial resources, tools, logistics, everything will come in that. Whether we have got skill, this is the part when we talk of WHO, GVCR, or Indian context, we have recently released mosquito vector control response or global vector control response. They say capacity and capability. Capacity of the human resource to deliver the services and capability of the system to deliver the services, to ensure that services are delivered. So the resources must be available, which will make the capability of the system. The skill of the human resource available should be there at different level. Everybody will not do national, state, districts, sub-districts, and then go to the primary health care or sub-centers or the village level. So everybody will not do all the works, but those who are requiring which kind of operation, they must be skilled properly. So the tools, which tools are available for use, for which activity, and then whether these tools are available in time with all accessories and all functional status. Then they should have some power. This is very, very important, especially for the urban areas when you go. The power to enter the house for spraying, power to check the performance of the services made available to the community, power to inspect the houses for larval breeding, power to enter the houses, to go to the top of the roof to see the breeding potential or breeding larvae, power to go for the construction sites, power to go to the industrial township. So the legal power has to be there for the service providers under public health system, especially for the vector control operations. Otherwise, because vector, they don't have a boundary. They do not have any boundary, whether it is you talk of the district, national, international, no, absolutely not. So if you are breeding and within their flight range, they are able to spread the disease. Now, how it will be done? Once you are there, these inputs you have provided, then you must do situation analysis, which will include the epidemiological. If you see the IBM components, the first part is that first pillar is that situation analysis, which includes little bit epidemiology also. Then vector control need assessment is very, very important part. And vector control need assessment, again, for one country, small country, it is okay. But for different district, different eco-geographical area, the vector control need assessment has to be done. There we have been talking earlier that it will be different for different area. Flexibility has been given in framework, but flexibility, what is required, that will come with the vector control need assessment. So these are the smaller fragments before we come to a conclusive vector control plan. Vector control need assessment will tell which area, which measures, what tools, and when, what is the timings. Then to implement those tools and technology, whether the updated guidelines are available. Again, there is a difference between guidelines and SOP. Guidelines will be a broader book, which I appreciate Dr. Mukhtar, because when I was reading his guidelines on the dengue control, it was very nice. And the mosquito fish, when I was searching for that, I have seen that guidelines when I discussed. So guidelines has to be very, very methodical, systematic, but simultaneously guidelines are never final lines. Guidelines has to be updated off and on, depending on the situation, maybe 5 years, maybe 2 years, maybe annually. If there is any change in the, or any innovations are included, the guidelines must come in time. Then quality assurance. Quality assurance to ensure the guidelines, that these are the guidelines which are, it can be done, it is doable, it is feasible, it is purely based on scientific evidences or experiences, and this can be included. Say, for example, I am telling one point that people, they ask, control program or elimination program is supplying LLINs, bed nets, and program is supplying insecticide pump, but program is not supplying the liquid vaporizers. Now the answer which I gave, that how liquid vaporizers, if at all it is included, what is the frequency, what is the requirement per house, per person, how many times he should put it, and what is the guarantee if you do that, what is the time limit, because some last for 6 hours, some last for 3 hours, some last for 2 hours, then what is the quality assurance for maintaining this? So program supplies and program recommendations are foolproof, that once it is scientifically proven that this is the shelf life, this is the efficacy, this is the sensitivity, this is the specificity, and this will last for this, and this is the replacement policy. So this is just an example. So certain things has to be processed under the quality check and quality assurance, as I told. Then what are the measures? Vector surveillance is first measure, entomological surveillance you call it. It's analysis, the data analysis rapidly. And after doing analysis, once we come out, then we have to suggest under integrated vector management, because some of the areas you have to have a different scenario. I will come back to that when you will appreciate that under integrated vector management, different scenario, different tools and technology, sometimes mixing, sometimes alone, sometimes 2, sometimes 4. So which is actually feasible and best suited for this particular scenario. So that measures has to be selected. Once we make all these things, then only we can expect the output of intervention package, no transmission or vector infectivity 0. Again, this is to be monitored, and then re-establishment is prevented. So basically, we expect our outputs. First is no indigenous transmission. Second is in the vector itself, 0 infectivity, that will be correlated with the receptivity. Even if its area is receptive, we have got 0 infectivity in the vectors. And then re-establishment of the disease in 3 years is completely prevented based on those. So these are the basic outputs which we expect finally after the vector control plan. So these are the 6 pillars which should be find a place in our vector control planning. And to do this, the experts who are making the vector control plan, they must have sound knowledge of biology and behavioral ecology. Without this, the vector control plan will be copy and paste. Let me be very, very honest and frank. The previous NSP you take, previous year, and just copy and paste and little bit change, it will not work like that. Then the process monitoring. Which time, which activity has to be monitored? If, for example, if spray is done, whether spray schedule is made, whether spray schedule is synchronizing with the transmission dynamics, whether spray logistics or approval is there, whether the fund is there, whether the spray squads are listed, finalized, whether the spray squads are trained, whether the functionality of the pumps are checked, whether the insecticides are there, whether the community, whether the roadmap is made and the community on the according to that plan of spray has been informed, whether the people have given the consent, otherwise suddenly you reach. Same is the case with LLIN. If you take LLIN, whether the stores from major store, mega store to the smaller store to the district level to the PSC according to the distribution plan, it has reached to that area, whether the people have been told, whether it is a mass distribution, it is a campaign based distribution, it is a house to house delivery, whether there is a buffer, proper buffer is made, because the procurement is made as per the norms, general norms of 1.8 persons, one net for 1.8, but people will not sleep in divided. So there has to be buffer stock because some of the time actual distribution. So those buffer plans. So all those things have to be processed, has to be monitored, and somebody should know all these things. That should find a place in our national strategic plan, especially the chapter when we are making the vector control plan. Efficacy of vector control interventions. Which vector control tools we are doing, whether it is scientifically proven for that area. If there is an outdoor transmission, whether we are recommending indoor spraying. If it is established, whether are we still hoping that there will be some impact, or there is some evidence that there will be not any impact. So why to waste? Why to invest? Because there is a series of financial involvement in that, right from the spray advisory, advocacy, pumps, logistics, insecticide, transportation, everything. So whether we are still convinced with that or it's not that. So all those things are to be quality issue. Then interpretation of entomological and epidemiological data for program decision. This is very, very important. Analysis part has to be done, and all the entomologists, I would request here who are listening, or they can disseminate, that they must understand how to analyze the data for the program decision. Because in my career, I have seen that most of the things are reports in the format are submitted, and there is no recommendation or no analysis part is made. This is very, very important. Prevention of onward transmission from each case. This is another important, whether we are, how to identify the cases and classify or characterize the cases, that should be found in the part, and little bit should come in the vector control plan, though it will be in detail, it will be part of the total NSP in the epidemiological section or the case identification, but little bit should come so that around that case or foci, investigation procedure should come, where the vector surveillance and entomological components and vector control part should be moving around, that this situation, 1 case, 2 case, 3 case, what we should do, whether we should do focal spraying or LLIN or fogging. Fogging is not recommended for malaria and WHO, but some countries they are still doing. So what is the local decisions, how they are doing, managing, or some source reduction or some biological control measures. So what all the available tools are there. Then how we are maintaining the transmission foci, where the transmission is going. There is one case, there is one foci cleared or not cleared. are active, and there are all transmission where the transmission is going on, though it is limited, it is patchy, but how we are managing, how people are reaching, where, how many people are there, what is the division of the labor, then how promptly we are able to institute our vector control and how it will go. 5 kilometers, 10 kilometers, 20 kilometers, if from the primary healthcare system where our entire team is sitting or stationed, if there is a village is having 2 kilometers, or there is a remote area 20 kilometers, especially you go in tribal area or hilltop area or foothill area, they have to travel a lot. So how fast they will be reaching, or what arrangements have been done for that. This should be a part of our vector control plan in detail. Regular training and monitoring is very, very important. And once we reach to that level, especially for the receptivity and vulnerability, this is very, very important. Who will understand what is receptivity and what is the suitability of that ecosystem? How to demarcate that area? Because this is because most of the area in rural settings is a contiguous area. So how to demarcate that area? For this area is receptive and adjacent area is not receptive. Then population vulnerability. What is the population coming cross border? Those area who are sitting at the international borders, or those within the district, endemic, non-endemic states or districts. So what is the movement frequency? And this is rampant. This is rampant in mostly in the nearby the mega cities. So, and then how to judge about the infectivity in the vector hospital. There are new techniques have come, xenomonitoring, PCR techniques. There are many techniques of the pooling of the mosquitoes and then seeing that. But who will do, how to collect the mosquitoes, where to send all these things. So these are the issues which should be addressed in our plan process. This is very, very important. The another burning area is urban area. This is last month only this guidelines have been disseminated by WHO, special vector surveillance plan in urban areas, because now there will a lot of pressure on the urban area, and Stephen's eye transmitted malaria. Now, what are the basic consideration when we make a rural vector control plan for rural areas, or tribal areas, or difficult terrains, or the urban area? Urban area, definitely vector control plan will be entirely different. And this we have experienced April, May in the malaria program review also. We did in Mumbai, we did in Surat, we did in Bangalore. So we have found correlation. Now see, what is the basically transitioning to urbanization? There is a statement in that WHO guidelines that by 2050, every 7 person out of 10 persons will be living in the urban area. So it means 70% population will be living in urban area. Not necessarily that they all will be living in mega cities, but the whole world will become trying to, because upscaling, living standard is getting higher. So the urbanization will be, even the rural sector will be urbanized. And when urbanized, there will be a water storage, there will be good practices, there will be some saving, but simultaneously the health services will not be able to match immediately. So the risk population will increase. That is the basic concept here. And the urban vector, primarily Stephen's eye, is having a different transmission dynamics. It is very, very difficult. The whole world is now discussing on the Stephen's eye related invasion malaria, African area. We have been suffering since the beginning. So we have got urban malaria scheme. We have got urban town scheme. So urban vector borne disease scheme. But who is implementing? So that part should come. Vector control plan is a technical portion of the entire strategic plan. It's not a managerial problem. It's a technical problem. Then in urban area, the whole urban city will not be at risk. There will be different component, different segments. So the micro geographic stratification has to be done. There will be some slums, there will be some construction laborers, there will be some market area, there will be some aggregation of people from different colonies, different tribes, different communities. Some people are coming in groups and they will try to stay in one place. There will be some places dirty, there will be some places very posh, there will be some places. So there will be difference in social determinants, and that will govern the transmission. So that is very unique to the urban ecosystem. Then to solve this, there are multi-dimensionals. If you see the society, which is harboring about 250, 500 people, 1,000 people, they will have neat and clean. But around that, the entire slum will be there. So multi-dimensional people, multi-sectoral response has to be inculcated, included in the our strategic plan, especially for the vector control. Because everybody would like to purchase one fogging machine and do, but that will not work. So we have to be very, very alert, and our system should be so strong that people, they start believing in our health system, which is actually lacking in the urban area. Mostly the people say there is no coordination. What are the considerations? Usually they do the focal spraying, but we have to advise them for the tailored approach. Which society, which area, which setup, what kind of approach will be there. Intersectoral coordination and responsibility has to be a part of this plan. PPP model, sometimes it works fantastically in the industrial setup or in the corporate sector. Nowadays, the system is that one area is demarcated for the corporate functioning. So many corporate offices, all electronic cities, everywhere, there are separate segments have come up for the business people or the service class people in the private sector. So they call it as an electronic city or corporate world. So those areas, how it will be protected, how it will be done, who will take the responsibility. So their PPP model definitely will work. Or in some semi-urban zones, many NGOs are coming up, so they may also work for the support for the PPP model. Commitment and support from local bodies, which is usually low, is very, very important. Without rules and regulations, without the governance of the health department, whether it is a provincial government, it is a national government, or it is a local body government, it is a municipal corporations, mega corporations, or municipality, or councils, or township, or panchayat, or the lower level. This is very, very important, so that they are first convinced. We always say that first when you talk, you confuse them what they are doing, then you convince them what you want to get them to do, and then you take a commitment from them that okay, now you are convinced, and you have given the commitment, please do that. So then resource mobilization based on the technical guidance, and technical guidance, the maximum emphasis should be in the urban setup, that influx of population. The population growth is actually, it is a population, not it is a population growth. We should say it is a population explosion in urban area. So they have to monitor the influx of the population. And then the legal measures like building bylaws, legal measures, that what kind of things are approved, should be approved legally. This is a crime if you are allowing mosquitogenic potential to increase in and around your houses. We have only 1 or 2 places where the legal bylaws are being implemented properly, and in fact we were trained in 1981-82 the Bombay municipal bylaws. So these are very, very important components which must be taken into our vector control plan preparation in the total national strategic plan of malaria elimination. What is it? What signifies? Why we are talking all these things? Vector control, what is the significance? Now see, as I told you, this is number A category was given by WHO, the first category for the vector control. Similarly, the surveillance also, which strengthens the public health, vector and pathogen surveillance has to be done by the capable persons, and this is very, very important. So this is one strength where vector surveillance finds its place, that without vector, if there is a transmission, if there is a malaria case, and who says that it is not gone anywhere, irrespective of entomologists and vector control experts saying that we could not find the vector, definitely there is a vector. There is no chance that without vector the survival, the transmission will be there. So vector and pathogen surveillance is most important. Then the response. Once you do the surveillance, response, once you see the 2 pillars, I have been telling that control is most important pillar. Otherwise, you go on doing the cases and you don't take any measures. So control of vector-borne diseases without vector control is impossible. So the response includes vector control, and for that vector control planning has to be a major important chapter in this total plan. Prevention, again, prevention which limits the total spread or vertical spread also, it boosts, but preventive strategy is also taken under public health measures if it is a major public health problem or it is a public health problem. So public health measures will include the preventive measures. But once you reduce the very low level, then it will be response to the case finding and focus liquidation, other things. So all the three areas, vector control has got its own significance. This is very, very important because that was the topic given in that my chapter. So I have included this slide. You see, vector control in reducing mortality is so popular across the world, all malaria endemic countries. LLIN not only kills, or the residual spray not only kills the mosquitoes, it also prevents the persons. Sometimes it repels also. So if you are killing the in mass vectors, it is actually avoiding, protecting the people who are sleeping, but also protecting some people. Otherwise, those population which are killed, they will go and bite somebody else. So in mass also, community protection and personal protection both are signifies. Another challenge of vector control planning is it reduces the vector surveillance, vector survival, vector control measures. It reduces longevity, so that the parasite is not allowed to develop, complete its lifespan, what is required, 10 days, 8 days, 10 days, 20, 12 days in the mosquito body. Otherwise, it will become the infective mosquitoes. But we must understand, this will work here, down below. But if they are sleeping outside, it will not work. So this photograph, I have not taken the photo of sleeping person. He was sleeping here. So this photo I only took it in the tribal community. He was sleeping. He suddenly saw me taking photo and he ran away. So if he is sleeping here, he cannot be protected. So these are the things. These are the things which must come in the plan, vector control plan. Now we know all these things. What are the vector control components? For the vector control components, if you talk of adult mosquitoes, LLIN, IRS, and fogging, though it is not recommended by WHO, but many of the countries they are doing. It is not recommended for malaria now, but people are doing in the urban area and locality because there is a visibility and other things. They are doing something for the public. Anti-larval measures, they are doing larviciding, they are doing biological control. Larviciding, they are doing with the chemical as well as biolarvicides also. Source reduction is another which for a smaller area, or when you land up in a very, very no cases or this thing, source reduction, though it is a permanent, but it is initially it is a costly affair. But later on, if you take the overall cost effectiveness, it becomes cheaper. There is no recurrent. So source reduction, the breeding sites, cleaning, flow, gradient, maintenance, everything. And then for these things, there is a code of practices, which we call it as a safe environment. So environmental code of practices, they must follow those, and this will be only linked with the quality assurance. So this personal protective equipments, or there is a transportation hazards, how to do safe disposal, everything is to be given in the code of practices, and that can be taken as an annexure, or a brief can be part of the vector control planning. This is very, very important. So these are the components of the vector control. But to accept these services, the capacity building or the advocacy at the individual level, at the helmet level, or at the different places, market area, water fetching area, or the community volunteers, everywhere you have to do the advocacy and capacity building, depending on their numbers, depending on their interest, depending on their cadre. So we have to talk all these 6 components we have to take for the vector control components. If we land up in situation I have showed you with the receptivity, with the API classification stratification. We have been doing the receptivity classification. But this classification is a practical classification, which we also see sometimes in the field when you land up in the area which is co-endemic with other diseases. Now, if you see, basic disease was malaria, where we have been doing entomological survey, and we have been doing entomological, what entomological survey we have been doing: vector prevalence, feeding, host preference, biting, resting, infectivity. But then in some area is overlapped with dengue and chikungunya, especially the urban areas, and now the invasion of albopictus in the urban area and rural areas coming as another major vector. So there is, then there is a vector visceral leishmaniasis, that is Kala-Azar. There is sanitation. So vector density will be here also. So your vector control plan is indirectly giving a collateral benefit to all other diseases also, LF, vector, VL, dengue, chikungunya, JE, though they are primarily JE is outdoor feeder. So there are some common vector control operations. There are some separate individual control operations. So those things also we must keep in mind, because we may land up and the question may come up that, okay, you have decided for malaria elimination plan exclusively in a vertical approach, but what will happen in certain situations here? So we must see, so that one person is going to larviciding, he should not go again, because there is a frequency fix for the larviciding. This is very, very important slide which we must consider in the format. Quality assurance at each level and effectiveness of the program is very, very important of the services. I'll just give one example. This is also from WHO taken. If you see, our program is efficacy is 98%. Any one component if you take, we claim that yes, we have been doing wonderfully well, and 98% efficacy looks very nice. But if accessibility is 60%, if 60% coverage or 60% population is covered with the accessibility, so you take 60% of this 98%, what if then diagnostic is available for all 95%? Good diagnostic system, surveillance system and detection system. But this 95% system will be for 60% people only. So if you take this 95% of this output, then even if we are doing the providing that compliance is also very good, 95%, because 100% we will never be. So some of the people will. Then 95% of this 95%, this 95% will be of this 60%. And then you calculate for patient adherence, if they are giving to 95%, means roughly almost all, and then patient are adhering to 70% maximum, then your total effectiveness, which you claim 98%, it becomes only 37%. Now, what is the answer for this? So we have to increase here. If we want to increase here, we have to increase accessibility. And that is what is our public health system or the surveillance system should be so strong, both in terms of service providing, detecting, providing the services. Otherwise, if this becomes 60%, all are coming down. So we are not even half, we are less than half. So in this situation, there will be very, very difficult to achieve the target. This is what I wanted to talk on today's lecture. What are the components? What is the national strategic plan? And what is actually our total components in the plan? We may continue tomorrow that what is basically surveillance in different systems. I think. Thank you very much. I believe, Leo, this is good enough. I have not taken much time.
Dr. Pradeep delivered like a maestro. The maestro at work. So I personally absolutely thoroughly enjoyed this presentation. It was wonderful to listen to. You covered a good number of very important topics. You explained very well. So I think a job well done. Thank you for that, Dr. Pradeep. You set a very high, strong example to follow again tomorrow. but you did very well. I think from all of us, a sincere thank you for a job well done. Well done, Dr. Pradeep. I'm clapping my hands, but I'm sure everyone else is also clapping their hands. There's Dr. Mukhtar and Mr. Joshi also clapping hands. Thank you so much. So we had a technical glitch which prevented many people from joining. So I'm extremely happy to see we have 93 participants that were able to join. But in order to bridge that technical glitch, it meant, if I understand correctly, everybody had to, or as many people as possible, had to be made panelists. And if you're a panelist, instead of just the usual attendee, it means you don't have access to the Q&A box. You can't post questions as a panelist in the Q&A box. So I'm going to suggest people who would like to ask a question, please raise your hand, the raise hand icon at the bottom of your screen. And then we will allow you to pose a question verbally. To be fair, I know that Dr. Mukhtar posed a question earlier on or he made a comment which could be transformed into a question. So I see Dr. Mukhtar actually has his hand up. So Dr. Mukhtar, please unmute yourself and allow us to see you if you don't mind, and ask your question.
Leo, before you invite Dr. Mukhtar, I
Yes.
have also one request to all my senior friends.
All right, please go ahead, Dr. Pradeep.
That if they want to clarify something or add on, they are welcome to add on, because it is for the knowledge of the all young people.
Thank you for that. Thank you for that. No professional jealousy or anything. That's very good of you. So Dr. Mukhtar, please proceed.
So thank you very much. First of all, I really thankful to Dr. Pradeep for a wonderful presentation. Really, no doubt he made a wonderful change to today, just in 1 hour in our mind, about some clarities. So being a vector control expert, I think this is a wonderful day that we have the opportunity to listen to Dr. Pradeep. A wonderful thought, and overall this was a wonderful presentation. No doubt, we have no doubt that is a good. So Dr. Pradeep, thank you very much for nice presentation. I have just few minor comments as one question. One question is a general question for entire community, entire technical expert, regarding the core intervention and supplementary intervention, because the Dr. Pradeep wonderfully explained the core intervention that the LLN IRS. So regarding the supplementary intervention, which is active larval source management, because it's sometime in the particular for dengue control, it works like a core intervention, because in the dengue control, we don't rely on the use of the LLIN or IRS, then it's a supplementary larval source management. So we should also make it some more clarity about the importance of the larval source management, particularly, no doubt for the malaria control, larval source management is a little bit not a core but for the other vector-borne disease is a wonderful intervention. So, but just my this is comments regarding the because we are talking about the elimination, as some countries are striving for the elimination, some for the control intervention. So is a general question that which intervention, particularly if I talk about the L Alliance, which is mainly supported by the donor support like the Global Fund, and you know that very sorry to say, unfortunately, the Global Fund is not very much interested for IRS, so they are only interested for L Alliance. So but sometime for elimination scenario, the IRS is a more importance for if we really want to achieve the ambitious goal of elimination. So this is my just comments as well as my question that which intervention for which scenario for control and for the elimination is more appropriate, in my opinion, because Dr. Pradeep also invited that if we want to add, in my personal opinion, IRIS is a more important as compared to LN for particular elimination strategy. So this is my question, as my comment. Finally, very important, and Dr. Luckily, I wrote a many questions, but coming slide, Dr. Pradeep answered that question. So it's a wonderful presentation. So we made a question, but then we also got the answer. My final comment about the fogging. This is a very interesting topic, because you know that particularly for dengue control in urban areas, we are doing a lot of fogging, and people are using it as a political weapon, the things like that. And sometimes I also, as a national vector control expert, I asked them about the question, what is about the efficacy of the fogging? And then we explain that if we do the fogging on a true principle of fogging, that definitely is the effective intervention. It doesn't mean that we do the fogging one day and we forget the area for next 1 month. So fogging means if we really want to get some impact of fogging, during the first week of the outbreak, there is outbreak, then we have to repeat on alternate third day. And then the second week is once in a week, the things like that, which we have explained our national guidelines. The overall fogging video and Dr. Pradeep very clearly mentioned that is not recommended for the malaria in many countries, but still people are using. So being the technical expert of this community, this is a wonderful forum that we should make some very good solid messages for the countries that which intervention should be used as an intervention. Otherwise, we are creating some misunderstanding about the efficacy of intervention. So these are my few points. And so if Dr. Pradeep, we want to respond as a question, warmly welcome. Otherwise, these are my comments as well as my points. So thank you very much, Dr. Pradeep, for wonderful presentation. Over.
So Dr. Mukhtar, wonderful words of wisdom, and also reflects many years of experience there, solid experience that you're now expressing. So Dr. Pradeep, it would be interesting to hear your response about the choice of LLINs versus IRS. My understanding is there's a significant cost factor involved here. And obviously, you know, financial resources are a limitation for many countries. And then Global Fund has its particular preferences as well. So it becomes a bit of a economic and political hot potato. But do you have any comments, Dr. Pradeep?
Yes. Thank you very much, Dr. Mukhtar. The first question or importance of LSM, I think we have got third session, the third day, that is vector control, plan, tools, option, flexibility, and situation based. So in that, it is actually the whole thing is there in answer in detail, situation based. But let me clarify that LSM has got its own importance in the area. The WHO uses term, we have also used the same term in our national guidelines also. Few, fixed, and findable. India, or if your country or any other country, African country, which are agriculture based, rural based countries, we can't go on larval source management across the country. So we have to select which area, few we can fix, and those where we can do. So larviciding is definitely a very, very important tool, which I'll be explaining in my third day topic. But this is a very good suggestion that importance of LSM, it is by and large for exclusively for when they were making malaria, they have taken core intervention for interruption of transmission. Because larval source management directly does not interrupt the transmission. It has got its role after 10 days or 15 days, it will be imperative. So they are also right. And we are also right in saying that LSM has got its own importance. And if you say when we started our urban malaria scheme and National Filaria Control Program units, 131 towns and 206 towns. Now there are 700 towns. Almost each village has got a like urbanized sectors. So everybody is trying to do use of temifos and the biolarvicides. So when there is a pipe water supply, there is a waterhead tanks. When there is a waterhead tanks, there is a use of. So absolutely you are fine. The second point we have raised that IRS versus LLIN. this is definitely a intelligent, intelligent question. And since we are making a presentation, training the people who how to make the plan, strategic plan, so I will reserve my comments. But definitely some areas IRS is more effective. Some areas LLIN is very effective. Like for example, I'll give my country example. If you want to go in Rajasthan and say that you use the very hot climate, you say you use the LLIN, people will not use. You go to Odisha, which has a showcase of India in World Forum for success story of LLIN use in reducing the malaria. There are many publications also have come for our Odisha state Daman project. But you know, they are also asking the same question, that in rainy season, when it is hot and humid, people don't use mosquito net, LLIN. So their effectiveness, their efficacy, their applicability goes down. And during that period, if you see the transmission dynamics, tomorrow I'll show that graph. So the curve goes up. Not because they are not effective, they are not used. So that limitation is always there. And then fogging efficacy, I appreciate your guidelines exceptionally well for that fogging which you have written. First, any outbreak situation. Fogging has always been recommended to contain the outbreak, because when the number of mosquitoes, which are primarily zoophilic, except few vectors, out of 56 vectors, total malaria vectors, and if you say in Indian condition, there are 10 or 9 vectors, 6 primary and 3, and then 1 is always debatable with the research and other our program people. There are only 2 which are very highly anthropophilic, others are all zoophilic. Now in zoophilic, when the density goes very high, then only the chances of human beings being bitten by this mosquito. So to reduce that density, at the dawn and dusk time, fogging was recommended, which was taken for JE later on, which was taken for dengue later on. But initially it was recommended in malaria program only. And so it was always a measure for outbreak containment. And you are right that first outbreak situation, immediately you should do first day, alternate third day, and then fifth day, and then on weekly intervals, because immediately you have to give the cut to the density. The second very important point is that you can start focally spraying immediately, whatever insecticide is available, irrespective of synchronization with other border areas, so that quick response is taken. So quick response with available resources has to be done. So this is very, very important point you have raised it. Thank you. Thank you very much. Yes, Leo, please.
Okay, thank you for raising that very interesting topic, Dr. Muller and Dr. Pradeep, your responses. Thank you for that. So let's give other people an opportunity. Anybody want to raise their hands? And I'm going to ask the technical team, APMEN technical team, please help me identify people who raise their hands. I don't, you know, sometimes
Dr.
don't.
Joshi.
Dr. Joshi,
Yes, sir.
please.
Yes, sir. So today's Dr. Pradeep Kumar deliberation cover all the 5 core of vector control elements to accelerate the progress. Also, so far elimination is concerned, and mainly he has put a more emphasis on maximize the impact of vector control. First, secondly, maintain the adequate entomological surveillance that will help in for the impact of the vector control also. At the same implementation of vector control strategy in context of integrated vector management. So nicely elaborated, give detailed information to the participants which requires at the state level. I have also worked at the state level, and so he mentioned everything. And so important aspect, he discussed urban malaria control plan. See, we can say urban vector-borne disease control program is also, and nowadays no plan is available. So at this juncture, as Dr. Mukhtar sir already told regarding the in urban area fogging and everything, and we have experience also in Singapore that the fogging is a false sense of protection if there is no larval control, what we can say, larval resource management or larval management also. So these are the important aspects. But at this juncture, what I believe that Dr. Srivastava sir had discussed regarding a very good risk effectiveness factor, and this is the need of the day. So far, this elimination is concerned. We invest a lot of say 100% or 90-80% in forms of efficacy, and we are getting or generating only effectiveness of 37%. So what are the gaps and challenges we face? We should find out such gaps and challenges, and if we put more pressure or more supervision or more implementation or maintaining such like SSCs, SS, diagnosis, as well as compliance. So, sir, before that, for adherence to malaria treatment, we have in APMEN regarding the adherence to malaria treatment at a large stage that has been discussed for P-Vivex, there's chloroquine and 14 days pemorphine. Similarly, for P-falciparum ACT. So these are the things which need to be much more emphasized. So for effectiveness, to gain the effectiveness more and more, say it is now 37%. We should increase this thing. That will be very, very important. So, sir, I'm thanks Dr. Pradeep Srivastava, sir, who is also our captain and leadership in vector control management as well as IVM also. And we have learned him many things from the different areas of the India also, sir. So thank you very much, sir. I have no other question, but the only thing for the urban area, there should be did very, very particular and meticulous planning to control, because Dr. Mukhtar has already raised a question regarding no land area in urban is concerned, and different demarcation is also there. So, sir, this is a very important thing, and Dr. Pradeep has already said that planning. Also, lot many gaps found in urban area. Dr. R.S. Sharma has been visited his area like Bombay. That area is Navi Mumbai and other area. I forget the name, but actually it requires much more importance to eliminate, to enforce the elements. So thank you very much. Thank you.
Okay, thank you, Dr. Joshi. Do you want to respond to that in any way, Dr. Pradeep?
No, sir, he has given all answers generally regarding all the response
Thank
for
you.
urban malaria.
I just want to respond with thanks.
Okay,
Yeah.
that's fine. I just thought maybe you want to elaborate, but okay. Dr. Ghosh, I'm going to come to you. I just want to mention that I've seen the questions. Dr. Mukhtar has additional questions he'd like to pose. Just asking you to wait for a bit. And I see there's a question from Ugyen Zangpo. We're going to get to you, but let's go to Dr. Susanta Ghosh. Please voice your question, Dr. Ghosh.
Yes, just not question, it's a, Pradeep is a, I congratulate you and just to take away, 2 hours just spellbound, thank you so much for giving overview, total overview, and just clapping is not enough, I tell you, but you have done excellent job. But 2 suggestions I'm giving you right now. If you talk of, asymptomatic malaria, I think we should not recommend RDT right now. If you do a normal surveillance is fine, but when you go for asymptomatic malaria, because I was reviewing an article where I found even WHO has given that, report that many countries, some countries is totally this, HRP2 and 3 genes are deleted. In Africa, one small country, and many countries, it is going up to the level of, 25 to 30, 40, 50%. I've got the whole list. So for asymptomatic malaria, I think we should not recommend for RDT. And second thing, Dr. Pradeep, I think we should highlight certain aspect like urban malaria when coming. There are a lot of public players, they are now in the vector control program, their own way they do. I think that part we have to look into, because even either where I reside, they have hired one, agency. They come, they fog, they do some spray here and there. So this is an important aspect we have not taken into, consideration in the vector control activities. Because you are very correct. I was looking into World Bank report that by 2050, 70% of global population will be, not only India, will be under the urbanization process. And Leo, you might be knowing how Stephen's eye is threatening, I think, everywhere. So I think we have to think of and dengue also, both urbanization area. So these 2 points are suggestions, and thank you, Pradeep, for your excellent talk.
Very well pointed out on those issues, Dr. Ghosh. Dr. Pradeep, do you want to respond to that?
Yes, Leo, to Dr. Ghosh, you are
Yes.
absolutely right. But the issue is, you know, that this is 4 days course. And
I know.
what you are trying to get it emphasis on the different scenario, again, this urban situation, that is actually on the 3rd day. So
Okay, good.
different scenario will definitely come. And regarding RDT in asymptomatic cases, see, the basic questions, you also know that in general, when you make a national plan, a strategic plan, and the theme of this course is to how to frame the vector surveillance plan and vector control plan. So we are not highlighting deliberately, or we are not raising any debatable questions here, which has some feasibility in some countries, some feasibility in some countries. See, if you don't have a microscopy facility, you don't have adequate numbers, what is required according to the population, according to your health delivery systems. So you don't recommend RDT and you go for, so that is a debatable thing.
Correct,
so our
correct.
focus is on vector control plan. Thank you.
Okay, thank you, gentlemen. Dr. Anju, I see your hand up, but there's some earlier questions that came up. But just to, I'm trying to be fair to everyone and go down the list, giving precedence to those people who were first in their questions. So there were a couple of people who asked whether this presentation could be made publicly available or sent to them. So, I think it's easier if we let you know. Well, first of all, I have to ask Dr. Pradeep if he would mind if we share his presentation.
No, please
publicly.
share.
Yeah.
Please share my all PPTs to everyone.
All right. So what we'll do is we will upload them onto the APMEN website, and we'll give you the link. We'll give you the link day or tomorrow or the day after, where you can access the full set of presentations. So don't worry, it's our full intent to make available this high level of expertise and skills for everyone to go back and re-look and share, because it's truly a wonderful set of lectures. So Dr. Mukhtar, I think you're next on the list. I think you had additional questions to ask. Please go ahead.
Thank you very much. Actually, I forwarded these 2 points because Dr. Pradeep, you are very right, and Dr. Also the colleague also rightly mentioned about the efficacy of LLI, because nowadays we are finalizing our next 5-year plan for the vector control. One of the question which is mainly asked by the communities as well as the social expert, that the use of LLI and its efficacy, because you know that the LLI efficacy mainly depend upon the feeding time of the local mosquito species. You know that the LLI people are normally used late night, because nowadays the media due to watching the TVs, they go to the bed at late night. But the feeding behavior of the local mosquito is start early sunsets. That's why this is one of the identified reason that we, despite the fact of 100% coverage of the local population, still many cases is at the same stage before the transmission, because the people use the bed net late night, they go to the bed to the late night, and while the feeding time of the local vector species just after sunset. So this is one of the identified. So I really love to see to listen your comments on this, because that this is the general question which is asked by the community as well as the higher authorities as well. Because just before this session, I was with the meeting with the secretary, who was wishing to have the bed net for, you know, there are severe floods in Pakistan, and they are asking about the bed net and its efficacy. So these are the general normally question which people ask about the efficacy of bed nets. And second, regarding very
Dr.
important.
Mukhtar, sorry. In fairness to our other participants, may I ask you to hold back on your second question? We'll come back to you, but I just want to give other people opportunity.
Okay, fine,
as well.
fine.
Sorry, yeah.
Fine.
So, Dr. Pradeep,
Can I have another question and then I can respond together
okay, okay.
with another participant? If we can have this another question.
All right, but this issue that Dr. Mukhtar raises now, you know,
Okay.
I think
I'll try to clarify.
One moment. You know, not everyone in the audience might be at the same level of experience and so on. So, you know, it goes back to the issue I raised very briefly, the issue of IRS versus LLINs. Given the shortfalls, you know, in uptake of the use of bed nets by a small percentage of people, plus the fact that bed nets miss the early evening biters and so on, why is IRS not made use of by national programs to a larger extent, given that, you know, you spray the wall, it's there from 6 a.m. to 6 a.m., not only used from 10 p.m. until 6 a.m. as bed nets are. But I'm not going to answer. I'll let you try and answer that. And also at the same time address the issue of Dr. Mukhtar about the early evening biting and so on. Thank you, Dr. Pradeep. Yeah.
I just wanted to say one thing, Dr. Mukhtar. This is when you take anything in public health program, you take by and large on an average scenario. There are specific scenario. As I showed you one photograph, that outdoor sleeping people, and there are many situations where LLIN will not work. I gave you some example of hot and humid climate. So early biter mosquito habits, dynamics also is one of the reasons where LLIN will not be effective. But does not mean it is the synchronization of the sleeping habit of the people and your service provider. So we just can't say LLIN effectiveness is a different thing. But which area it will be effective, which area it will not be effective, that is the part of the planning, that how much quantity we would like to have. We cannot sit in one place like this, say for example in Delhi. We can't sit and say whole country, all 1,000 million people, 1,200 million people, you give the bed nets. So that is what the part of the planning, that you assess receptivity, vulnerability, acceptability, feasibility, and then you take a commodity, logistics and managerial issues. Thank you.
You still haven't addressed the IRS issue, Dr. Pradeep. In Africa, as you're well aware, it's been demonstrated very well, thoroughly, the efficiency of, efficacy and efficiency of IRS. Why is it not more highly used by national programs, either as a supplement to bed nets or as a replacement to bed nets in certain situations?
Recently, there was, if you see, I saw one paper from Africa only, because LLIN is not effective. If high burden malaria area is there, where high level of transmission is going on, IRS immediately cuts down. Whereas, and we have been using IRS since 50s. LLIN has always been secondary. LLIN was introduced only after 1995 or 97. So LLIN was earlier secondary. It is now very recently, when the case load has gone down in many of the countries. Now this WHO document says that core strategy LLIN 1 and IRS, because IRS is under phasing out slowly, because you don't have third compound, fourth compound. You have been using DDT, which is under phasing out or almost phased out. You had organophosphorus, which is not acceptable, basically precisely malathion. Then you had synthetic quetzal at some group, resistance has started coming up, picking up faster. And then you have some carbamate, which is only one compound, which is still under the high toxicity zone. Then now some new compounds have come up with long-lasting insecticidal IRS applications and neonicotinoids, but it's still they are under the debate still positions. Though they might have cleared, some might have cleared with the PQ, but they are under debatable conditions. So what choice you have for public health program? That is why LLIN is more easy for use in the public, whatever level of extent. And we have never published any data that 100% security is given by IRS also.
Thank you, Dr. Pradeep. Now, I asked that question because I don't want us to focus too strongly on elimination countries. We have several colleagues from Africa here, which may be in high burden countries. So, you know, I wanted to bring in IRS as well. I'll just get your comments on that. But thank you, I understand. There's a question here. Oops, where's it gone to now? So the question is, in what, I'm not quite sure I understand it, but let me read it again. In what kind of situation do we keep the malaria case unclassified? And will that classification be accepted by the WHO if a country goes for elimination? It's by Ugyen Zangpo. I'm not sure I understand the question fully. Dr. Pradeep, do you get the question, or should we ask Ugyen to explain?
I'm not able to see that question.
Ugyen, are you still with us? Can you activate yourself and elaborate a little bit?
Yes, sir. In one of the present PPT slides, I've come across 3 classifications. So I'm just curious to know in what kind of situation do we use that classified malaria case? In one of the case classifications, there is unclassified case. So I'm curious to know in what kind of situation we use that classification, or whether that classification will be accepted by the WHO for elimination.
Am I understanding you correctly that you have an unclassified case where you're not sure if it's local transmission or if it's imported, and that's going to affect your application for certification? Do you have a comment on that, Dr. Pradeep? It's a tricky one.
See, by and large, with epidemiological classification or case characterization, what has been given, it is not with the species. It is basically, it is a transmission wise. It is an indigenous transmission, induced or imported. And if the format is not correctly given or the information, see, if the is not correctly filled or analyzed, then the possibility will be there for case not to be identified or characterized in that particular group. Say, for example, I will give one example, unclassified cases. You go to a hospital, just take a list of the patients who were declared positive. You see the address, Mr. Ram Kumar, Bihar. Now, that doesn't say. Most of the time, people, they don't give their proper address, proper time when they have come. Whether they have come in last 7 days, 10 days, 15 days, 20 days. In that case, the analyzer or the data analyst will be very, very difficult to do the proper analysis. So if those things are taken into account, then only the case can be classified. Without proper information, sequential information, the case will remain unclassified.
Yeah, I think the question was actually meant in a different way. Do you want to clarify more? Ugyen, I'm not sure it answers your question. Do you want to?
Or if he can, if they can pose a specific question, a specific case, then we can little bit more elaborate on
Yeah.
it.
Sir, so my question is actually, I thought it is one of the case classifications, because in the slides under case classification, yes, doctor has mentioned unclassified case. That's why I'm curious whether that classification is there in the guideline or not, because I haven't seen it in the WHO guideline. That's why I'm curious to know if that is the one of the case classifications.
There is all 4 or 5 classification given by WHO, and if because of any reasons those 4 or 5 classifications are not characterized, then it will go in unclassified. Then there will be detailed classification or some tracking will have to be done, because case has to be classified finally.
Yeah.
Thank you. Now it's clear.
All right. I mean, it's an interesting topic again, but I think at the end of the day, if it's one single case that they genuinely can't classify as local transmission, indigenous transmission, or imported, I think a country will make every effort to resolve that question, because it holds back the country from, being certified. So, and it will very quickly, within weeks, you'll know whether it's local transmission, because there might be, there should then be additional cases arising. But so I don't think in the bigger picture of things, in terms of a country applying for elimination status and so on, that one single unclassified case is going to make a huge difference. I may be wrong. Dr. Anju, your turn next. A question from you. Please feel free to state the question.
Yeah, good afternoon, sir. So first of all, I thank you, the organizers, for conducting this course and giving us an opportunity to hear from sir. So as usual, Srivastava sir's class is informative and interesting. Thank you, sir. And I need to clarify just one thing. So actually the thing is that currently we are using the vector control strategies as per the API categories. So when the API comes down, obviously we will withdraw the vector control measures. So in some areas, what happens, the cases are, there is an upsurge of cases or an outbreak is coming. So at that moment, what are the vector control measures we have to do instantly, or what are the methods to maintain the malaria-free status of that area?
Very good. Very good. But again, I will tell that this is a part of third day session, where we have given vector control plan, tool, option, flexibility, situation-based application. But just to answer your query and clarify for all others, that details will be there on the third day session. But just to clarify that we are also in the process of NSP, and our previous NSP and operation manuals in context with the Indian situation, there was a different scenario given. The classification was on epidemiological, which now has to be changed on taking 3-4 other parameters also. And if you are getting less number of cases, you have to go by absolute case number. That is only one criteria. Then you have to go by risk factors, receptivity, vulnerability, and the mosquito prevalence, mosquito population, which is the vector influence, because ours is more complicated, because somewhere 2 vectors, somewhere 3 vectors, somewhere 4 vector complex area. Outdoor, indoor, you have to take the transmission. Then we have to decide the vector control measures. Basically, vector control measures are same, the tools which I have shown. Larviciding, adulticiding, and source reduction, and then advocacy, and because this is the component of the IVM. But which particular tool will work where, which we have been discussing with Dr. Mukhtar also, that LLIN versus IRS. If LLIN and IRS both are working, good enough. If not working, IRS alone will working, or LLIN is working, or source reduction is working, or in some area LLIN larviciding is working. Please go ahead with that. So that different situation, we have got some slides, so we'll be showing, but that is basically on third day. Thank you.
One more thing. It's as per Dr. Ghosh sir mentioned, no? Asymptomatic malaria. So mostly in our places during MSAT only we are finding out these asymptomatic malaria cases. So during the MSAT also what is happening, only we are doing the RDTs. So how can we, is there any criteria to define what is the asymptomatic malaria? If a person without symptoms, we can't tell like that, he is asymptomatic. So is there any definitions for particular for asymptomatic malaria?
I'll answer quickly, Leo, if permission is given.
Sure, please go ahead.
Basically, when we are thinking of elimination, the first aim is to ensure all the cases are captured. Now we know the lacunae in the system. So the mass screening was allowed. It was done even long before elimination target. We have been doing FRT and MRT after doing a mass survey, and then those things were in between gone. Now the mass survey and treatment has come just to take out if the people are there. So even if the gametocyte, asymptomatic malaria was basically termed for the gametocyte carriers, because they do not have. But nowadays with this different scenario, asymptomatic malaria you capture. The problem with RDT is that we are not going to get the stages, whether this is going to set right. That is why the concern of Dr. Ghosh was there, that if we can do microscopy, but whether the facility, whether the skill, whether the training, everything is available. If it is not there, at least you get the load by RDT. Thank you.
Thank you so much.
Thank you. I'm sorry, Dr. Mukhtar, I stopped you from asking your second question and I allowed someone else to ask a second question. It was asked before I could. I felt I would be rude if I interrupted. So Dr. Mukhtar, please proceed with your second question.
So thank you, Dr. Pidhi. You very rightly mentioned about the selection of intervention based on the multiple factors like the sleeping behavior, the feeding behavior of the local vector species, and then acceptability, things like that. So wonderful. My second is again a question plus comment, because being a national program manager, I always ask this question, and I face the problem because we are no open community and we are discussing, we are sharing our experience regarding the, you mentioned, very rightly mentioned about the urban and rural areas, because you know that in our Indo-Pak subcontinent, even in Africa, that these urban and rural is demarcation based on administrative demarcation, not purely from the malaria and effect of the mosquito breeding point of view. I just give you the example of the Pakistan, that administratively we have 70% urban areas and 30%, 70% rural areas and 30% urban areas. But actually, in some Balochistan or some poor provinces, which is 100%, we can say that the rural areas. But just because of this administrative demarcation, we leave the 30% area, which is actually the malaria affected area. So this is, so you can take it as my comment that we are to be very careful about the demarcation about the urban and rural. Sometimes we declare it as urban, and by law we can't go there for intervention or implementation. At the same case with India, I know Dr. Sharma has a lot of debate with me, and you also sometimes we discuss this issue, and so we have to be very careful, because this is one of the reasons that if we really want to achieve the elimination goal in the region, we have to be very careful about these definitions, that urban and rural, so that we can go for the implementation of the intervention. So this is the case from Pakistan, that we have officially 70% urban area, rural area, sorry. But actually, when we go to the field with respect to the malaria and other vector bodies, it's 100% rural areas, particularly like Balochistan and some provinces which are backward provinces. So this is just my comment. And if you want to respond, warmly welcome. Otherwise, this is just my sharing of knowledge from Pakistan.
Thank you for that, Dr. Mukhtar. Dr. Pradeep, any comments?
No, this is actually happening. The only thing I would like to add that now slowly the boundary between urban and rural is vanishing. Earlier, when we joined in 80-81, we used to travel, and then you see that, look here, that is the village and this is the urban area. We have crossing, and in between there was nothing. Travel 800 kilometers, 900 kilometers, whether you travel in India. Recently I traveled in Timor-Leste. you hardly find a place where there is a gap. So continuation. And you know what happens, though it is again the third day syllabus, but we did during my regime, we did one very important thing. Our integrated system is a very, very robust under National Health Mission. And we have issued a guidelines. There is a Village Health, Sanitation and Nutrition Committee, VHNSC. I personally made it included, and that circular is still there. People are using or not using, that is a different story. But the guidelines is that the fund which is allocated to them in the local panchayat and rural settings, they can use for larviciding also. And then larviciding specification, dose, everything is given. So that makes them empowered, that empowers them to purchase locally larvicide and use in urbanized villages. Thank you.
Yeah, it's fascinating. I was just by coincidence, I was reading recently, a week ago or so, a Lancet commissioned paper on trends for the rest of the century in terms of human population growth and all the ramifications, public health and global health consequences and changes in focus that need to take place. But it was saying United Nations apparently recognizes 2007 as the point where, for the first time in history, there were more people living in urban environments than in rural environments. And I think the projection is by 2050, more than 70% of the human population will be living in urban areas as opposed to rural areas. And you're right. I mean, you travel from city to city, and there are very few areas where you can travel through in many countries where there's no sign of human influence or human dwellings or some kind of human impact visible anywhere. You know, human impact and human dwellings, the lines are graying, as you pointed out, Dr. Pradeep. Fascinating. So it has lots of consequences for public health. You're quite right. So here's a comment here from Rupa Shivakoti, who says, thank you, Dr. Pradeep, for your wonderful presentation. Non-adherence to LLINs is a big issue. Will you please share any successful story or practice to improve its adherence? Any suggestions from you? How, you know, given that it's almost impossible to get 100% uptake within communities to use LLINs for very good reasons, is there at least some ways to improve uptake? Over to you.
Thank you. This is a very, very important question. And for the benefit of others, we have been projecting our Daman issue, that is basically a campaign-based malaria elimination or malaria control or malaria reduction, significantly in Odisha. Odisha used to be in the high stubble malaria zone in India and contributing the maximum malaria cases, where they have taken their own initiative to ensure the coverage improvement in LLI, and not only distribution, but its usage, monitoring, and they have shown significant reduction. If she is more interested, I can share that paper with her, because this is a big paper recently published by Dr. Pradhan. It is a really success story, and I mean, one must read that paper, that how it started in a campaign mode, how everybody was contacted, how people were trained, and their capacity was intensified to ensure that they are using. Last night users practices were monitored, and that has really given a complete dent on malaria incidence in Odisha state. And now Odisha state, from it is dropping down and approaching towards elimination.
Thank you, Dr. Pradeep. Yes, I think several people in the audience would be interested in having access to that paper. So maybe tomorrow, if you wouldn't mind, you can just copy the link, you know, the URL where people can access that document. That would be great.
Right.
We're approaching almost 3 hours now that it's wonderful. And we still have 90 people attending. So it shows the level of interest, and it shows your expertise, Dr. Pradeep, in keeping people involved and the high level of interest. Dr. Joshi, question from you. Please go ahead.
Joshi, PT Joshi.
Joshi.
Small question, not question, but sir, for rural and urban algorithm, WHO and our in elimination global control strategy also, there is introduction of foci-based investigation, foci-based case management, foci-based intervention is there. It is an alternative to whether it is urban area, whether it is a rural area, whether it is a tribal area, whether any paradigms for malaria transmission, foci-based investigation, foci-based intervention is the only answer, I think, to my knowledge and information. Okay,
Good.
thank you, sir.
Thank you.
Thank you.
Thank you, Dr. Joshi, much appreciated. So just to comment, Wulan kindly said, yeah, we'll share the recording and PowerPoints in the OREN website, orene.org. Wulan gives the website there. Under the training drop-down list, but she will be sharing the exact link later in the week where one can access the presentations by Dr. Pradeep. So here's another one. I think it's from Dr. Porn from APMEN Secretariat, just to say that you can access this presentation tomorrow, you know, the course, using the same link that you used today. So when you want to link up tomorrow, and I suggest try and link up 5 minutes before starting time, use the same link. So I don't see more questions. Let me just go through. Does anyone see? If I don't see your hand up and you want to ask a question or make a comment, please unmute yourself and go ahead. Otherwise, we're going to end today's session. I'll give it a minute, see if there's anybody still wanting to make a comment, ask a question. Anybody? Well, what a wonderful day. It's been a truly wonderful session. Dr. Pradeep, thank you so much. To all our participants, thank you for your high level of interest, for the very good questions. It's been a most stimulating session. I think we all enjoyed it, and we look forward to tomorrow for yet another one coming up. So same time tomorrow, 1 p.m. Bangkok time, 2 p.m. Singapore time. We look forward to hopefully having all of you back and being able to absorb the wonderful experience and wisdom of Dr. Pradeep. Have a good day, everyone. Keep well.
Thank you. Bye-bye. Thank you. Bye.
Bye-bye. Bye-bye.
Thank you, sir.
Thank you very much, Dr. Pradeep, and thank you, Dr. Liu, for wonderful session.